So thank you very much to the organising committee for my invitation to this meeting. I've been asked to talk about the role of endovascular hemostasis in blunt visceral trauma. I think patients find themselves in three broad categories when they undergo severe blunt trauma. Hopefully they can be in a group that doesn't really need much apart from resuscitation and supportive therapy. Some have no choice because of their extensive injuries or associated injuries, which mean that they must go for open surgery. And we now find there's a group of patients who are amenable to endovascular treatment. So what tools do we have? Well, you've just heard about the 𝗔𝗶𝗏, which is a sort of temporary occlusion system. Mostly we use devices that occlude arteries, and those are coils, plugs, sometimes some liquid embolics, and spungistan, which is a sort of reconstituted porcine fat, which can be made into a paper mache with contrast. And of course, if there's a major artery injury that we can cover the whole of, then we can put a stent graft in. So there's been a recent change to how blunt abdominal trauma is treated or recommended to be treated, and this was generally published by the World Society of Emergency Surgery back in 2020, and they produced these several patient algorithms for kidney trauma, liver trauma, and for spleen trauma. Now, they make it very clear, but these are not standards of practice, but they're suggested plans of care, and they're based on the best available evidence and also on an expert consensus. But actually, each individual patient needs to be treated related to the local resource and the local expertise that's available to them. So, in general, what those sort of algorithms or patient pathways generally say is that rather than anatomical grade of injury, the treatment decision is based on two things. One is the hemodynamic stability of the patient, and the other is their extent of their injuries. For example, if there's a bowel perforation, then they'll have to go for surgery. I find that cases that are appropriate for endovascular hemostasis are generally in two broad categories, or two categories. One is the opportunity to get hemodynamic stabilization without open surgery, and the other one is in the stable or stabilized patient who is at risk of failure of non-operative management. So who is at high risk in the stable group? Well, if you've got blunt trauma to the liver or kidney, then actually you've got a very high chance of not needing anything doing apart from resuscitation or and rehabilitation. Even if you see on the CT active bleeding, it's not necessarily an indication, if you're stable, to go and do anything. If you've got a focal injury like a pseudoaneurysmal 𝗍𝗏 fistula, if you have a hilar injury, or in a renal injury the 𝗔𝗏 fascia is ruptured, then those are higher risk groups where they may benefit from an adjunctive procedure. The spleen is a more fragile organ, and I'll deal with it separately, but that's why it's more commonly injured and it's more likely to be fatal. So here's a case that came to the trauma centre in Leeds, high-speed RTA, patient unstable. You can see here that a 𝗔𝗶𝗏 balloon has been put in on the CT scan, a little bit low for this extensive high-grade liver injury. The patient, that 𝗔𝗶𝗏 balloon after the CT scan was raised. The patient was taken direct to surgery, and obviously this required damage control surgery. Following surgery, however, the patient remained unstable or difficult to stabilize, and so then came for angiography, and you can see here that they continue to have a false aneurysm of an intrahepatic artery, which was occluded with a combination of coils and actually glue. Of course, they've made it a little bit more difficult for us by having a replaced right hepatic artery. Another case of a high-grade renal injury, a chap who fell from a ladder, actually after resuscitation was completely stable and required no further intervention to stabilize him, and actually that kidney recovered. And here are a couple of examples of renal hilar injury. On the left, an unstable patient, and you can see on the CT scan that there's a big hole in the main renal artery there, and that was treated with a stent graft. And on this patient on the right side, this was at a branch, more difficult to choose a stent graft here, so actually the vessel was occluded using coils and a plug, and in fact that kidney then infarcted obviously and became an abscess, and the patient required surgery at a later date to remove that. So complications, apart from infarction and abscess, are generally treatment failure and the requirement to go on and actually need operative management. There are some further more low-grade complications which can usually be treated, particularly biliary leaks usually just or a myeloma require a drain. The spleen, I think, is a much more difficult organ in blunt abdominal trauma, and there are suggested rates of up to 40% fail with non-operative management. And this can actually improve with embolization to about 90% success rate. Of course, that has to be accompanied by the standard therapy of bed rest and observation on an ITU or a high observation unit. There are two techniques to embolize the spleen. There's the proximal technique where a plug or coils are put in the main mid-main splenic artery, or if you see a focal vascular injury, then you can go out into the periphery and treat that. Both are equally effective in preventing further hemorrhage. The distal technique has a slightly higher minor complication rate. Both preserve splenic function. So you do not need to put these patients on prophylactic antibiotics, and they do not need vaccinations. Complications are similar to the other solid organs. You can get infarction, abscess, and of course sometimes a pleural effusion on the left side. Another example here is in fact a case that wasn't done very well in Leeds. So this chap fell from his motorbike, perfectly stable, but because of the mechanism of his injury, he had a CT scan, and I don't know if you can see it, but all he had on his CT scan was this very minor defect on the lower pole of the spleen. And in fact, that was misreported, not as a traumatic lesion, but as perhaps maybe a previous infarct or something. The patient was discharged and 5 days later collapsed at home with pain. And as you can see, actually that was the CT undercalled that injury. He had an extensive injury, obviously it continued to bleed and then ruptured. So he was then obviously rushed to hospital, went straight to angiography. Well, after a CT scan, went straight to angiography. And you can see here that the angiogram, there's no actual active bleeding seen on the angiogram, so he was treated with a proximal embolization, and after the usual observation period was discharged without any further complications. Another just a case of a focal lesion which was treated with distal embolization again in a cyclist, but you can see there's a focal vascular injury which is at high risk of rebleeding if you leave it, and so it's just treated. And this guy again went through the usual bed rest and observation, was discharged without any further intervention. Just another case of a stable patient who you can see on the arterial phase scan actually has high-grade renal injury, but he also has a blush, which you can see on the later phases. Again, on angiography, you can't see any evidence of active bleeding, even though the CT has picked it up. So he was treated with a proximal embolization successfully. This is a more woeful tale. This chap was, as you can see, he's an alcoholic patient. He's got a TIPS in situ. He's got cirrhosis. And he was picked up by the police. We don't quite know what led to his collapse and how he was treated, but he collapsed in the cell and then was rushed to hospital. resuscitated, given the supportive therapy, and I went to CT scan. I apologise, I've taken way too long. So he went to CT scan and basically had a stable injury. He was put on the ward. He then was fine for 48 hours and then collapsed again. And rather than go to embolisation or theatre, a repeat CT was arranged, and he died whilst that CT was being done. And the point of that is that patients with cirrhosis and splenic injury are very high risk and actually have a very high mortality rate. So the conclusions really are that embolisation has two major roles, really. It can be used in immediate hemodynamic stabilisation, and also as an adjunct to non-operative management, particularly in splenic lesions. Thank you.